Today we will start Kawasaki disease. Okay, Kawasaki disease. Now this video is made for the purpose of the PG students, especially postgraduate in pediatrics, and also some points will be there for undergraduate too. But it is a detailed elaboration of the disease, which will enable you to diagnose, to treat the disease when you see a patient in your outdoor. Now, what is Kawasaki disease? How will we read the disease? We'll divide the disease into the definition of it, the epidemiology, the pathogenesis, the pathology of the disease, the criteria for complete KD. For further discussion, we'll mention the Kawasaki disease as KD. Okay, and the disease spectrum spanned over acute, subacute, and convalescent phase. We'll discuss this later, and the other organ involvement that we'll also read. And later half, probably in the next video, we'll read the incomplete KD, the diagnosis of that, diagnosis of incomplete KD, as well as the echo criteria, and lastly, treatment. So this is our plan of reading the disease. The first thing that we'll try to read now today is what is the definition of the disease. What is the definition of Kawasaki disease? Look, when I was a resident, there was no clear teacher who will clear cut the difference between the vasculitis, the small vessels, the medium vessels, the large vessels. Now, Kawasaki is a vasculitis. It is a medium-sized vessels vasculitis, medium-sized arteries which will be involved here. What are the medium-sized arteries that are involved? So first thing is it is a vasculitis. It is a vasculitis involving what? Medium vessels, medium-sized arteries. Now, what are the medium-sized arteries? Most commonly involved are coronaries. Other arteries, yes, may be involved like axillary, like iliac, but these will always be involved in the presence of coronary artery. Without the presence of coronary artery involvement, axillary and iliac isolated involvement cannot be there, and even popliteal artery may be involved. Okay, but visceral arteries are usually are not involved. No, visceral arteries are not involved. Okay, understood. Now it's a vasculitis, which is a medium-sized artery vasculitis, which is self-limiting. If you do not do anything, there will be some complication, but usually it is a self-limiting disease. Etiology with unknown etiology, and presenting as acute febrile illness, mostly involving or mostly affecting less than 5-year-old children. So understood? So what is the definition? It's a self-limiting medium-sized vasculitis, medium vessel vasculitis with unknown etiology, presenting as acute febrile illness, mostly affecting less than 5-year-old children. Now that's the definition. What is the history? A brief. First, Tomisaku Kawasaki. He was the pioneer of this. Tomisaku Kawasaki in 1967 described every spectrum of the disease and published subsequent papers with different complications and manifestations of the disease. And he was the pioneer. Recently he passed away. He was a pioneer of Kawasaki disease. Okay, before that, the disease, not as Kawasaki, but the spectrum was described by Munro 4 like this. It's spelled Munro 4 in 1959. and even Itoga in 1960. Whatever, but Tomisaku Kawasaki was the pioneer for this. Next, we'll be going for the epidemiology. Epidemiology. So mostly it's involved. We have already said the less than 5 years old children. Mostly it is involving the less than 5 years old children, and if we see closely, there is a shift in the involvement of the Kawasaki disease in different part of the country of the world. Sorry, different part of the world, because as you can see, there are initially mostly the children of Asian population was involved. Even in the Japan, this occurs. In Japan, it occurs usually 6 to 11 months. That is the most commonly involved age group in Japan. And incidents are rising, incidents increasing in Japan, Korea, Taiwan, China, and other Asian country, even India and other Asian country. Whereas incidence is decreasing. Incidence is decreasing in USA, and most of them who are affected are of Asian ancestry. Even it has been seen that siblings of the affected KD children in Japan, they have also the high risk of contracting the disease. Though the etiopathogenesis is not known, it may be infectious, it may not be, but it has been seen that the high risk of contracting the disease. So that's a part. And even second and third attacks have been encountered in 3%, 1.5 to 3% of the cases. Second and even third attacks in 1.5 to 3% of cases. And some say it has also seasonal occurrence in some countries. Japan, highest incidence in the winter and spring. In Japan, it is in the winter and spring. And even in the Taiwan, it is incidence in the summer. That's the highest incidence. So it has some seasonal occurrence. But what is the that is the epidemiology. Now, what is the etiopathogenesis? Why does it happen? Now, pathogenesis, nobody knows. In clear cut, nobody knows. We do not know. The first thing, it should be clear to you, nobody knows. But yes, some theories are there. Definitely there will be some theories, because it's so debated topic. So some says there is an infectious origin, some infectious agent harm the vessels, mostly the endothelium. Some says no. Some says as there is IgA producing plasma cell predominate in the blood, hence maybe the pathogen entered through the mucosal surface. Pathogen entered through mucosal surface. That may be one cause. If at all it is not due to pathogen, it may be due to a super antigen. Some says it may be due to super antigen producing by staph and strepto, staphylococcus and streptococcus. But the only known disease which is caused by super antigen is TSS, toxic shock syndrome. So again, it is debatable whether it is a super antigen or not. And some says it is due to that super antigen that BCG reaction happens. You should know that many patients of KD may show a reactivation of BCG scar. So there may be some kind of mycobacterial unique reaction to the mycobacterial antigen, and for that reason maybe this reactivation occurs. Some say so, but we do not know for sure. And some other theories are also there, like some says that some single nucleotide polymorphism may work. Some says which is the negative regulator of T cell activation, that might be affected, and in turn cause a genetic defect which is producing KD. But we do not have to need all those things here. We are going to pathology then. What is the pathology? What happens here? Whatever the reason be, we do not know the pathogenesis. Nobody knows. That's the primary thing. Now, what is the pathology? The first thing that you should know is it's a systemic. Each and every word is important. It's a systemic necrotizing. What is it? It's a necrotizing vasculitis. Okay, causing or with necrotizing vasculitis with fibrinoid necrosis. What is that? What is fibrinoid necrosis? Fibrinoid necrosis is nothing but the deposition of fibrin in the necrotic debris. You know, the inflammation and the secondary stuffs. And you should open the Robbins pathology book, and you should see what is fibrinoid necrosis written there. So fibrinoid necrosis is due to the fibrin deposition into the necrosed material of the vessel tissues. Of which vessel? Of medium-sized vessels. Medium-sized muscular arteries. Okay, muscular arteries. So that's the pathology. Okay, now that's the vasculitis. The first phase, there are 3 phases of it. Okay, the first phase. First, what happened? First phase, there is neutrophilic necrotizing arteritis. What is it? Neutrophilic. First, neutrophils entered. You all know that innate immune attacks, neutrophils are the first soldiers that reaches the site of the infection. So it is, we do not know is it an infection or an autoimmune disease or something else, but neutrophils invade the necrotizing invade the arteries and produce neutrophilic necrotizing arteritis. First involved, primarily involved involves endothelium, right? Endothelium, then and moves through moves through the muscular arteries, muscular wall of the arteries, right? And that will create what it is. What will this create? Saccular aneurysm, right? Saccular aneurysm. That's the first phase. Now in the second phase, what happens? Second phase, there will be subacute or chronic vasculitis. That is a subacute or chronic vasculitis that will be driven by lymphocytes, which will be driven by lymphocytes, plasma cell, eosinophil. So this will cause fusiform aneurysm. So first phase, what we said, what is a saccular aneurysm? Saccular means like a sac, just like a sac, right? What is fusiform? Fusiform means this. That's a fusiform. Okay. Now the third part. In the third phase, the last phase, what happens? Third phase, that smooth muscle myofibroblast will be developed. Myofibroblast will develop at the site. So fibrosis and eventually stenosis. So distally ischemia may be there. Thrombosis may occur also. Thrombosis. thrombosis uh, may occur at the site. Okay, so what we have read already. So we have read the definition, we have read the epidemiology, we have read the pathogenesis, we have read the pathology. Now the criteria for complete KD. Now we are coming to the major part. What is it? The criteria, right? What is the criteria for complete KD? The criteria. The first, before I tell the criteria, there are two types of KD. We all know what is complete and another is incomplete. We'll read in details about the both. The first thing that we should read, although, is complete KD, right? So what is a complete KD? Complete KD. The first thing, the criteria. Before telling it, I'll mention a few things more. You should always know that 25% of untreated children will develop coronary artery aneurysm. Coronary artery aneurysm. We have already said how the aneurysm develops. Okay, we do not know what is the cause. We know what is the usually epidemiology of that things. Usually less than 5 years. Usually mean age is around 3 years. But 25% of untreated KD will develop CAA, or that means coronary artery aneurysm, and it is the leading cause of acquired heart disease in children of developed country. So acquired heart disease in developed country, the leading cause is Kawasaki. Okay, the leading cause of acquired heart disease is KD. And the next thing that we should know is uh, most children who never meet the criteria are prone to develop CAA. Prone to develop CAA, coronary artery aneurysm, than who develop. It is 20% versus 7%. It is incomplete KD and it is complete KD. Okay. And the next thing you should know, the youngest patients are more prone. Youngest patient will not develop all the spectrum of KD. All the spectrum of KD. We all know that. So it is them, unfortunately, youngest patients are more prone to develop CAA. Hence, always remember in your practice, always remember, if any children less than 12 months old, or preferably less than 6 months old, some says, with unexplained fever for more than 7 days, should screen for echo. Should screen for CAA always by echo. Always remember. Okay. So what we have read, we have yet not read the criteria for complete KD, but we know that the KD is, I'm just repeating once more, it's a self-limiting medium-sized vasculitis which is mostly involved in the coronaries. It may involve the axillary artery, iliac artery, popliteal artery, right? It may involve all those things, but visceral arteries are not involved, and it presents as acute febrile illness. We'll see that, mostly affecting less than 5 years old. Tomisako Kawasaki was the pioneer in this. Less than 5 year old, mostly 3.5 years is the median age. Asian populations are mostly involved. Japan, it is 6 to 11 months. Incidents are increasing in the eastern zone of the world, and the western zone it is decreasing, and mostly whoever are involved, they are having an Asian ancestral origin. Siblings of KD, there is a high risk of contracting the disease. Second and third attack 1.5 to 3% of the cases. In Japan's Taiwan, there are some seasonal variation for that. Pathogenesis, we do not know. Why does it happen? We do not know. Just there is an aneurysm of the arteries and several other manifestations also there. What are there? What is the thing? The pathology we already know. In the first phase, there is a neutrophilic infiltrate and saccular aneurysm. There is a second phase, there is a subacute phase, lymphocytes, eosinophil plasma cells, and fusiform aneurysm. And lastly, myofibroblast will develop and fibrosis and stenosis may be there with or without thrombosis. Now, the criteria, the first thing, the must criteria. Okay, what should be there? It should be there. Other than that, it is not KD. That is fever. The first thing is fever. Fever into 5 days or more. There is a catch in this. 4 days of fever will be included in the criteria. 4 days of fever if treatment with IVIG or intravenous immunoglobulin eradicates the fever. That is a catch here. Okay. Other than that, for UG, it is fever for 5 days or more. But for PG students, you should know that if there are 4 days of fever and the fever subsides with treatment of IVIG, you have started early, you have suspected that it may be KD, you have started IVIG maybe on the 3rd or 4th day, and just after starting it, you have just eradicated the fever. That's it. That means that will also be counted here. Plus any, so fever plus any 4 of the following. How of the 5 actually, any 4 of the 5 signs or symptoms that I will describe below. Okay, the first thing, okay, what is this? Bilateral conjunctival injection. Bilateral conjunctivitis which is non-purulent and sparing the limbus. That's it. But if there is exudative conjunctivitis, no, not KD. And other features may be there except conjunctivitis. Other features of KD may be involving the eye, maybe anterior uveitis. That may be also associated feature of KD, right? That may involve the eyes. Now, second criteria, what? Changes in the oropharyngeal mucous membrane. What happens? Changes in oropharyngeal mucous membrane, lips and tongue. So from forward to backward we will go. What happens in the lips? Lips, fissured and cracked lips. How is it seen? How can you know that it's a fissured lips? Look, this is this is the conjunctivitis part. Okay, this is a conjunctivitis, non-purulent conjunctivitis involving bilateral eye. That's it. Okay, and I do not have the mucous membrane picture, but this is the strawberry tongue picture. Okay, that is the strawberry tongue, and there is a, I do not have that fissured lip picture. Whatever, fissured lips, and you should search that in the net, and you can get the fissured and cracked lips. Okay, there may be some strawberry tongue that I have already showed you. How does it produce? The filiform papillae, actually, sloughed off. They actually sloughed off. And persistence of fungiform papillae. Yeah, they persist. So it's like a strawberry. You can see it. It's just like a strawberry. These are the fungiform papillae. Okay, I can see these are the fungiform papillae, and the red part, this is the filiform papillae which has been sloughed off, totally sloughed off, right? So that's the strawberry tongue, and we are coming from forward to backward, right? So we have said lips, we have said tongue. Now the mucous membrane, of the pharynx and oral mucosa. The mucous membrane will be reddened or erythematous mucous membrane, right, of oral mucosa and pharynx. Okay, so that's it. Now that was the second part. Now what is the third part? The third part is the changes in the peripheral extremities. What are the changes in the peripheral extremities? Changes in peripheral extremities. Peripheral extremities. Okay. What are the changes? There will be erythema or edema of the hands. What are that? Erythema or edema of the hands. Okay, hands and feet. Of hands and feet. And or you can see periangle discomission. Now there is a catch. Periangle discomission usually seen in the second to third week, whereas edema you can see in the first week of the disease. So periangle discomission, if you have to see this, you have to wait for second or third weeks, mean at least 10 to 12 days. You should wait for that. And one thing I forgot to tell you, the mean duration of the fever in case of Kawasaki disease is 12 days. If you do not treat it, usually it lasts for 12 days. I have already said that it's a self-limiting disease, but it will have some complication for that. Okay, now 4. Oh, you have to see the picture of this. You can see, yes, this is the erythema. Okay, the erythema and the swollen hands, you can see. Now this is the discomission. Okay, this is the discomission of the hands. This is the discomission you can see of the hands. Okay, and we are coming to rash now. I'll see the picture later. What is the rash? There is the polymorphous rash. You can see polymorphous rash. Polymorphous means different kinds of rash, except bullous or vesicular. Vesicular rash is very, you should not go with KD. It's a non-vesicular rash. Non-vesicular rash and predominantly involving the trunk. Predominantly in the trunk. Okay, in trunk. Now this is the rash. This is the rash, if you can see. Okay. Now he has the rash in the limbs, but yes, there is some rash on the trunk. Predominantly it involves the trunk and also the limbs and in the periangle region. Now perineal region. Sorry, the perineal region will discommit. That's a catch here also. Also in perineal region. Now perineal region, that will discommit around 6 days. Discommits around 6 days. That means in the first week, right? First week. So what we have said, the discomission, periangle discomission means the nails part, this part was in the second or third week. But if you see perineal discomission, that is in the first week. Other than that, it is second to third week, but perineal discomission, it is first week. And the last thing, that is cervical lymphadenopathy. Cervical lymphadenopathy. Usually it is unilateral. At least one node more than 1.5 centimeter. No, that's it. That is the criteria. Okay. That is the criteria. Now, fever occurs almost 100% of the cases. If you see, that is 100%. Bilateral conjunctivitis, 90% of the cases. Now this erythematous, this is also around 80 to 90% of the cases. Okay, edema, that is around 80% of the cases. And lastly, the polymorphous rash, it is also, it occurs more than 90%, but what you have to know, the cervical lymphadenopathy, that approximately occurs in 50% of the cases. Not all, not at all. It only occurs in 50% of the cases. Okay. Now, what then we will just revise the criteria. What is the criteria here? The essential criteria is fever. Essential is fever. Fever into 5 days or more. Usually the mean duration, it is the mean duration. It is the mean duration which is 12 days. For PG students, you should know that 4 days of fever is also included into the criteria if the treatment with IVIG eradicates the fever, and the fever occurs in 100% of the cases. Any 4 of the 5 signs and symptoms. What are the 5 signs and symptoms? Bilateral conjunctivitis but non-purulent, sparing the limbus. If exudative, not KD. Enterouveitis is the other component that may be associated with conjunctivitis. Changes in the oropharyngeal mucous membrane, lips and tongue. We already know that fissured and cracked lips may be there. Now vertically, if it is the lips, if it is the lower lip, this vertical cracked fissures will be there. Cracked lips will be there. And there will be strawberry tongue. There will be filiform papilla, sloughed off papilla. Filiform papilla will be sloughed off. And fungiform papilla will be there, which will persist, and that will look like a strawberry tongue that I have shown you. Redent and erythematous mucous membrane of oral mucus and pharynx, that we know, and changes in the peripheral extremity that I have shown 80% of the cases. Polymorphous rash except vesicular. Vesicular rash is not there. Not if it is vesicular, it is not KD. If it is vesicular, it is not KD. And cervical lymphadenopathy, usually unilateral, and it is non-suppurative. Always remember, it is non-suppurative, and it also involves the anterior group, and it is non-suppurative, means non-pass forming. If it is pass forming, there may be pyogenic lymph node abscess or something like that, maybe cold abscess also for TB.